So first off, I'll give you your schedule. So today is our first special topics. You'll notice in the schedule is red. These special topics are not actually given to histology, but the purpose of these special topics is to allow you to have an introduction or a little sample to your second year course, which will be pathology. And the reason why we're doing this is because during the board exam, pathology is one of the lower scoring subjects that our takers take. Okay? So it's a difficult topic, and we hope to introduce it to you a little bit as early as first year. Okay? So throughout the year, we'll have several of these special topics. All right? And so for our schedule today, we will be having our special topics today on cell injury, cell death, and adaptations. Then later on, after the lecture, you will have a free lab for those who wish to continue looking at the slides, or those who have not yet drawn the slides or have their signature. I'll also show a few special slides related to my topic today, but it's completely optional if you want to attend or not. So you can go after this. Right? Then for next week, we will be starting on the cardiovascular system. Okay? The cardiovascular system, your lecturer will be Dr. Joy. And that would also be after her lecture, it will be batch springs that will have the first lab. Then the week after that will be batch cuboidal with Dr. Orfe, same topic, cardiovascular system. And then the week after that, which will be October 8th, will be your first practical exam for histology. Okay? So your practical exam for histology will be created by Dr. Orfe. You will be responsible for creating the exam for both sections. Okay? It most likely will include in the morning a PowerPoint exam, and then in the second half of the morning it will be an actual moving exam. Okay? More details to follow when the date comes closer. Alright? And then that's going to be our schedule. And then for next week also, your exam would be respite. So we have 24 questions created by Dr. Castelia, and then we have an additional 11 questions coming from today's lecture. So that will be the coverage for next week's block exam. Okay? Any questions regarding the schedule? Questions or concerns? None? All right. So let's now talk about our first topic of pathology. Right? So the Bible for pathology for all med students is Robin's pathological basis of disease. Okay? There are different versions of this one. This is the main one. There's also a little baby Robins, that's like a review series of the big Robins. But you should at least read the main book. Okay? Only later will you read the baby Robins. Okay? So this is the book you're going to use next year. So to give you a little experience. Right? Robin's pathological basis of disease. Right? So we're going to start off first with how do we process these tissues? And in fact, how do we process the tissues that we have even for histology? Okay? So these pictures I'm going to show you are actually my specimens when I was a resident. So what we have here is we get a specimen. In this case, we actually have an organ. This organ is the kidney. Okay? So if you see the anatomy of the kidney, it's supposed to be smooth, right? Well, what do we see here? This kidney has a lot of cysts. Okay? You see some cysts like here. Okay? Here is the cyst. Okay? So we see several cysts, and then look at the size. It's very large. Okay? So when we get the specimen, we always assess it grossly. Okay? We look at it grossly, we take measurements, we take the weights, then we section it. Okay? We section it. So here I have divided the kidney in half. And when I open the kidney, we'll notice that there are a lot of cysts of varying sizes. Okay? Cysts of different sizes. And they're filled with this clear, serous, somewhat brown, yellowish fluid. Okay? So, anyone want to take a guess at what this is? It's okay if you don't know because you're only first year. Sometimes you can make diagnosis based on gross appearance. Sometimes you'll need the microscopic appearance. This one's pretty obvious. This is polycystic kidney disease. Polycystic kidney disease. Central cyst replacing the parenchyma kidney. Adult polycystic kidney disease. All right. Here's another specimen of mine. We have a placenta. Here's the placenta. Here's the umbilical cord here. And it looks like it has this little twisting area here. It looks like a knot. But actually this isn't a real knot. It's called a pseudo knot. Don't need to know that. So there are things that you can diagnose grossly. Other times you'll need a histological evaluation. So what do we do if we want to take a histological evaluation? So we cut this into very small chunks, and we place them in this little cassette. Okay? So here's the cassette. So this is actually a portion of the placenta, and I cut it, and I made it small, and placed it in this cassette. Here's the picture of the umbilical cord that I also dissected in half. What can you say is wrong with this umbilical cord based on the gross appearance? Since you've already studied the connective tissue and you should know a normal histology of the umbilical cord, what's wrong with this umbilical cord? What's wrong with it based on the gross appearance? Do you know? You should know. You already studied this in the connective tissue. How many blood vessels are there supposed to be? How many do you see here in this slice? 2. Okay, so this one was missing the other umbilical artery. So this was a single artery, single thing. Okay? So some of these times you can actually diagnose it closely. Okay? So what do we do after we put it in the cassette? Okay? So after we put it in the cassette, I'll show you a little video. So, this is what we're going to do. So we put the cassette in this tray.
Early in the morning, the blocks are removed from the processor and they are taken to the embedded station to be embedded. At the embedded station, the blocks are placed into the mooring well to keep them maximum time. The tissue removed from the cassette and put into molten wax.
So after it's processed, we put it in the wax.
Once the block is cold enough, it will be removed to the ground.
So you can see here the tissue embedded in the wax, and then we put it on a microtome. And it slices it into very thin slices, like 2 cells thick. Then they'll put it here in the water bath to stretch it. And then you see how she puts it on the slide, and then from there, it can be stained, which is usually H&E stain. And then after that, you put the cover slip, and then that's how the slides are produced. And that's your final product for these slides. That's how we get our tissues, okay? Whether it's for histology or for pathology. Okay. All right, so let's get on with our lecture properly, okay? That was just a little introduction of how we process the tissues, right? So this is actually chapter 2 of Robbins. So what is actually pathology? Pathology comes from the word pathos, and ology. Pathos means suffering, okay? And ology is the study of it. So literally translated, pathology is the study of suffering. But in a modern sense, the term suffering refers to diseases. Okay? So in a modern sense, pathology is the study of diseases. And it is important because this is the field that will connect your sciences with the clinicals. Okay? It's going to incorporate everything together. So it has a little bit of your anatomy, your physiology, as well as the clinical aspects, the clinical manifestations, and everything else. So When we talk about pathology, it's the study of the structural, biochemical, and functional changes in the cells and tissues. Okay? And there are two branches of pathologies. Okay? If you become a pathologist, you can become an anatomical pathologist, which usually focuses on the biopsies and anatomical aspects. Or you can have the clinical pathology, which is more dedicated to the laboratories. Okay? Your laboratory studies and everything else. Okay? Or you could actually choose to do both. Okay? Or choose to do only one of those two. And so for next year, you will actually have two types of pathology. You'll have the anatomical pathology and clinical pathology. Both are very different from one another. Okay? So don't expect it to be the same. Okay? All right. So I forgot to put recording on something else. Okay, so let's talk about the four aspects of diseases. For a disease to occur, you need four aspects. Okay? The first aspect is the cause, or the etiologic agent. It's the etiology. This cause can be environmental or genetic. So examples of environmental would be, of course, your bacteria, viruses, fungi, amoebas. Those are all environmental etiologies. And for genetics, that could be, of course, you could have Down syndrome, which is due to trisomy 21. You could have different genes that make you susceptible to tumors. So, but most of the time, many causes are actually multifactorial. For example, let's talk about hypertension, high blood pressure. Okay? Hypertension is a combination of your genetic as well as environmental in terms of your lifestyle. Okay? So people that are obese, they don't exercise, they are prone to being more higher risk for high blood pressure. Okay? So many cases are actually multifactorial. Next, we have the biochemical, or also known as the pathogenesis. So this is the biochemical or molecular mechanisms of development that causes cellular events to change. Okay? So basically, what happens at the molecular level? Okay? What happens at the molecular level? For example, for diabetes, you have the body becomes resistant to insulin. That's insulin resistant, type 2. Okay? Then we have the structural alteration. What happens in the cells? What can you see under the microscope? Okay? So, for example, when you have probably pneumonia, so pneumonia, you would expect to see immune response in your lungs. You could see probably leakage of fluids. Okay? So that's what you see in the microscope. That's morphological changes. And then together, all of these changes, the biochemical and the structural changes, will lead to its clinical manifestations. What can you see? What are the signs and symptoms of the disease? Okay? Those are the four aspects of disease. Okay? So let's talk now about what happens when a cell becomes injured. Okay? So a normal resting cell is at a state which we call homeostasis. Okay? Homeostasis means it's at equilibrium. It's doing what it's doing, it's working functionally, it's doing everything that it's supposed to do. Okay? That's homeostasis. But if the cell undergoes stress, okay, it has to adapt or it will become injured. Okay? So we'll talk about the various examples of adaptations of how these cells can adapt to various stress. Okay? So what is an adaptation? It is a reversible, meaning it can go back. If the stress is removed, the adaptation can go back to normal. That's what it means. It's reversible, functional and structural changes due to physiological states and some pathological states. So stresses can be physiological or pathological. For example, if you have your muscle cell and then all of a sudden you start working out, that puts stress on the muscles. So the muscles have to adapt to this increased workload. So we'll talk about that a little bit later. Or it could be pathological stress. Perhaps a patient is suffering from heart disease that's having reduced blood flow to the heart. So the heart is not getting enough oxygen. So the cell has to adapt or else it's going to die. Okay? So these are some of the states that are pathological or physiological. So these adaptations allow a new steady state to be achieved and allow the cell to continue to function. So these adaptations allow the cell to continue living. or else it will die. Okay? So let's talk about the changes that can occur. So these are very important. Okay? So here are the adaptive changes that cells can do. The first adaptive change is called hypertrophy. Okay? Hypertrophy is an increase in the size of cells. Okay? So the cells can become bigger. That's one adaptive mechanism. We'll talk about each of them in detail a little bit later. This is just a summary. Next, you can have cells that can increase in number. So that's called hyperplasia. Okay? So cells that can increase in number can only occur in cells that are capable of mitosis. Okay? That's how cells reproduce, mitosis. So certain cells that do not do mitosis, such as what cells don't really do mitosis? Anyone give me an example? Anyone? Okay, neurons. Neurons, they don't regenerate. Okay? If you lose your neurons, they're gone forever. Also, cardiac muscle and skeletal muscle, they don't actually do mitosis. Very seldom do they do mitosis. So they can't do hyperplasia. Next, we have atrophy. Atrophy is a decrease in size of the cell. So the cell will shrink. Okay. Then the next one, you're actually familiar with the next one, okay? Because we actually seen it in our histology lab. It is metaplasia. Metaplasia is a change of phenotype in cells, meaning one cell type is replaced with another cell type. The one that you saw in the laboratory was actually the trachea. Meaning of the tracheas in our laboratory belongs to that of a smoker, right? So the normal lining epithelium, which is supposed to be pseudostratified ciliated columnar epithelium of goblet cells, is replaced by a different type of epithelium, which is stratified squamous most of the time. That's squamous metaplasia. But there are actually different types of metaplasias, which I'll show you later. And it doesn't limit only to the epithelium. Sometimes the connective tissue can also have metaplasia and turn into other types of tissue, the most common of which is bone and cartilage. Okay? So you could have tissue that will suddenly turn into bone and cartilage. Okay? These are the 4 common adaptive changes that you can see. And let's go into detail about each of them, all right? So the first one we're going to talk about is hypertrophy, okay? It is an increase in size of cells. Now, why did I show these very athletic people? Well, the classic example is muscles, okay? A physiological example is muscles. So, when we look at the normal muscles, okay, you have normal muscles, we have here on the left, that's a normal muscle. But what happens when you start to weightlift, okay? That adds stress to the muscles, okay? And in order for the muscles to continue to function, they have to adapt. So their adaptive mechanism is that they will increase in size. And when they increase in size, there are more contractile filaments, allowing the muscle to contract with greater strength. Okay? That is hypertrophy. So you can see this in bodybuilders, okay? When they get really big and bulky. The number of cells remains constant. So remember that skeletal muscle, they don't normally do mitosis, so they can't replicate in numbers. Okay? So what they do instead, they increase in size, okay? To create a greater strength. And this is what you see. This is actually, you learn this in the musculoskeletal system, but this is a cross-section of of muscles. So this is actually the muscle fiber. Okay? This is a cross-section view. So the muscle fiber is going towards us. So you look at the size. This is the same magnification. Here's the size here, and take a look at the size here. Much bigger, right? So that is hypertrophy. Now, this can also be pathologic. Let's say, for example, we have a patient that has high blood pressure, okay? But he's not compliant to his medication. So he doesn't want to take his medication, or he's being stubborn. So what happens? The body cannot deliver oxygen. So the heart has to work harder, right? But cardiac muscle also doesn't do mitosis. So what's the end result? It's going to be hypertrophy. And when you get an enlargement of the heart, that's called cardiomegaly. So I had one time during my one of my autopsies case. So we had a patient that passed away, hypertensive for 10 years, no compliance to any of his medications. So you know the normal size of a heart is about the size of a fist. Okay? So when we opened his chest, look at his heart. The heart was about the size of my partner's head. It was really huge. So imagine the size difference. So here's the normal heart, and it's, well, my head's a little bigger, but anyways, you can see the imagination, right? So you could have drastic hypertrophy, all right? It could be physiological or pathological. Next, we also have in pregnancy. So pregnancy is another physiological type. So here on section A, we have a picture of the uterus. Okay, there's two uterus. Here's a normal uterus here. Okay, and then here's the cervix is down here. So cervix is down here, the uterus is here. But during pregnancy, the uterus will enlarge. Okay, because there's a baby, it has to get bigger. So the muscles will also enlarge. So here's a picture of smooth muscles, and then you can see that they are much thicker here. Okay, they're enlarged. So another example of hypertrophy, pregnancy related. Right? So next, let's talk about hyperplasia. Okay? Don't confuse hyperplasia and hypertrophy; they're different. Okay? Hyper means over or above or beyond. Okay, so hyperplasia is an increase in number of cells. So this can occur in only tissues that are capable of mitosis. Okay? So here on the example, the diagram, we have a normal number of cells, and then here on the right, we have an increase in number of cells. Okay? So let's give you a classic example. I know you don't know it yet, but I'll just tell you what it is. This is a normal, non-lactating breast. Okay? This is a normal, non-lactating breast. What you see is, what's this tissue here? You know this? Oh wait, sorry, my pointer's not showing. Here, what's this tissue here? Okay, we do have areola. Areola is here. This is the areolar connective tissue. What about here? Adipose. Does it have to be specific because there are two types of adipose? So it's unilocular adipose tissue. So that's the breast. You have areolar tissue, which is here. This is the areolar connective tissue. It's loose connective tissue. Here's the adipose tissue, and then you also have these structures here. These structures are actually the glands of the breast. They're small because it's inactive. So these are the small glands, and then they drain into these little ducts. Then these ducts will drain into the lactiferous ducts. Okay? So this is a normal, inactive, or non-pregnant breast. Okay? During pregnancy, hormones will stimulate the growth of the glands to prepare it for lactation. So when you look at a breast of a lactating or pregnant woman or person probably towards the third trimester, there will be an increase in number of glands. That's why sometimes when you get pregnant, you'll notice that your breasts become bigger, okay? Or they become a little bit irregular or something. So this is what it looks like now in a pregnancy-related breast or pregnant breast. Now you have a lot of glands. So the glands have replicated. They've done mitosis, and you see some of the glands here and ducts are filled with secretions, which are actually with the breast milk. Okay? So this is hyperplasia, an increase in number of cells. Okay? This is a physiological cause. Next, we have an abnormal cause. We have endometrial hyperplasia. So the endometrium is actually the inner lining of the uterus. Okay? So the endometrium is actually the portion of tissue that's sloughed off during menses. Okay? So during the menstrual period, when the woman is bleeding, this is the tissue that's being expelled. Okay? It's called the endometrium. Okay? We'll learn that about in the female reproductive system. Okay? So normally in the endometrium, you have these well-organized glands, okay? And they're going to change shape throughout the menstrual cycle. But in endometrial hyperplasia, which is usually due to hormonal imbalance, there's an imbalance of the hormones which will promote the proliferation of the glands of the endometrium. So the glands become, here's the normal gland on the right, they're in the proliferative phase, they're usually straight. They're straight and well organized. But take a look at the glands here. some of them are really dilated. They're dilated, and they're not always very straight. They're going in kind of awkward positions because the glands are multiplying beyond the normal regulation. That's hyperplasia. Okay? And this is a very common cause of heavy menstrual bleeding, okay? Endometrial hyperplasia. Next, for our male example, we have a prostate gland. Okay, so let's look at the normal gland here. Up here is the urinary bladder. This is for a male. Okay, so this is the urinary bladder, and this organ here, this light tan organ, is the prostate gland. Okay. Now, this disorder is very common in the elderly individuals. So what happens is there's usually the testosterone levels would actually promote these cells to replicate. And when it replicates, the entire prostate will become enlarged. And this will be benign prostatic hyperplasia, BPH. Have you heard of that disorder before? Very common in elderly, BPH. So what happens, because it's enlarged, it's actually going to compress the urethra. Okay? So urine will have difficulty in coming out. So when the patient wants to urinate, you'll notice that his urine is not very strong. It's not a stream. It comes out maybe drop by drop, which we call dribbling of urine. Okay? And sometimes after they urinate, maybe 5 minutes later, they want to urinate again because the urinary bladder was not able to fully empty. Okay? So this is common in old men, elderly men. You see them, they frequently urinate. They can't urinate. Their stream of the urine is not so strong. And then even in the middle of the night, they want to wake up and urinate. Have you ever seen anyone who is familiar with those symptoms? It's very common in Philippines. It's BPH, and it's due to hyperplasia. So see how you have to know your anatomy and your histology to understand how the disease works. That's the beauty of pathology, putting everything together to understand how the diseases would work. And then if you know that, you can also understand the treatment. So the treatment of this are usually directed to testosterone, to reducing testosterone levels. Therefore, reducing the signaling of the cells to multiply and then go back to normal. Okay? Next one, we have atrophy. What's atrophy? Okay, decrease in size of cells. So here we have a brain. The left side is a normal brain. The right side is a brain that underwent a stroke. Okay? Cerebral vascular disease. Okay? Stroke. So the cells died. So you'll notice that the size of the brain is smaller and that the sulci and the spaces are here. The spaces here are much more bigger. There's more empty space because the cells died. And neurons cannot replicate themselves. Okay? So they will shrink and then they will die. Okay. Next is metaplasia. The first one I will give you is squamous metaplasia, the one that you saw in your laboratory if you had the trachea of the smoker. Okay? So here's the normal diagram of the epithelium, pseudostratified columnar with cilia and goblet cells. It's gradually replaced by a stratified squamous. So what happens in the smoking lung? So smoking has a lot of carcinogens, toxins, and very harmful products. Now, the pseudostratified columnar is not meant to withstand those toxins and carcinogens. Okay? It's meant to have cilia to produce mucus and expel dirt and other foreign substances. That's what pseudostratified columnar does. But because of these toxins, what the body does is it will replace the tissue with something that can withstand the toxins, and that's stratified squamous. Stratified squamous is like your skin. It's thick. It's thick. It's able to withstand a lot of toxins. Okay? So you have here in the diagram, here's the actually very nice picture. Here's the normal, but you can see it's gradually being replaced by stratified squamous. Now, that's good because stratified squamous can withstand the toxin, but it's a double-edged sword. There's a downside. Okay? Stratified squamous does not have cilia. Stratified squamous does not have goblet cells, so it can't produce the mucus and it can't expel and trap foreign particles. But the most dangerous thing is metaplasia serves as a very good ground for the development of cancer. And do you know the most common type of cancer in the lung? It's actually squamous cell carcinoma. Squamous cells. They originated from here. So that is the very important danger of squamous metaplasia. It is a very excellent fertile ground for the development of cancer. Okay? But luckily, this is reversible. These are reversible adaptations. Okay? They are reversible. All right, here's another one. So we have a portion of the lung. We see an alveolar sac here. So this is probably a bronchi, although there's no cartilage. But you can see the lining epithelium, stratified squamous. So it's been replaced. That's squamous metaplasia. That's the one you saw in the lab. But there are other types of metaplasia. You could also have something called intestinal metaplasia. Okay? So here I will show you. This is the normal gastroesophageal junction. Okay? This is the junction between the esophagus and the stomach. What's the normal lining of the esophagus? It is stratified squamous. So that's the one on the right. On the left is the stomach, which is lined by simple columnar. Okay? So this is a normal gastroesophageal junction here. Okay? Are there goblet cells in the stomach? No, because the columnar cells themselves will actually produce mucin, so they don't need goblet cells. But we can have something called intestinal metaplasia. Intestinal metaplasia. Okay? What happens is your esophagus and the columnar, the normal epithelium of the stomach will be replaced by epithelium that looks like the small intestines. What's the lining epithelium of the small intestines? You guys don't have confidence in yourself with this. So it is simple columnar with goblet cells and also microvilli. But more importantly, what do we see now? There are goblet cells. Okay? There are goblet cells. So the most common cause of this is intestinal metaplasia. This condition is actually called Barrett's esophagus. When you see your squamous epithelium that's being replaced by epithelium that looks like the small intestines, that's intestinal metaplasia, that's Barrett's esophagus. So the most common cause of this is something called GERD. Have you heard of GERD? GERD is gastroesophageal reflux disease. So what happens in GERD is, normally you have a sphincter, a muscle at the lower esophagus. So this muscle prevents the reflux of acid into the esophagus. Okay? That's what it's supposed to do. It's closed, so acid doesn't go up into your esophagus. Okay? But what happens in GERD? In GERD, the muscle doesn't close completely, or sometimes it spasms and it opens spontaneously. Okay? And so what happens is that you have a reflux of acid up into the lower portions of the esophagus. Now, the stomach is designed to handle the acids, right? Because it has mucin. The esophagus, not so much. It's corrosive to the stratified spines. It's an acid, you have hydrochloric acid. It's very corrosive to the stomach. So instead, what happens is it will replace it with cells that will produce goblet cells, the intestines. Okay? That's intestinal metaplasia, Barrett's esophagus. Likewise, this is also a fertile ground for carcinoma. And for the esophagus, the most common of the lower is actually going to be adenocarcinoma, because these form glands. Okay? They're forming glands coming from this lining epithelium. Okay? So that's Barrett's esophagus. It's intestinal metaplasia. Okay? Here's another picture. We see at the top of the epithelium is stratified squamous, right? We see stratified squamous, but we see the goblet cells here at the bottom. Okay? So the epithelium is going to gradually be replaced by intestinal type epithelium. So those were the four types of changes: hypertrophy, hyperplasia, metaplasia, atrophy. Okay? What happens if the adaptation is not enough? Okay? If the adaptation is not enough, or if the stress is severe, the cell will become damaged. Okay? It will become injured. Okay? So what are some signs that the cell is being injured and causes? So here are the causes of cell injury. The most common cause of cell injury is oxygen deprivation. Okay? And this is usually due to reduced blood flow. Okay? There's not enough blood going to the cells, so they don't get enough oxygen and nutrients. You could have physical trauma. Okay? You could have chemicals, drugs, infectious agents. Even the own immune system can cause injury. That's why we have autoimmune diseases. Okay? Or there can be nutritional imbalances, all causing injury to the cell. So if the adaptation fails, then you get injury. And this injury can't be reversible up until a certain point. Okay? If the injury is severe, you get irreversible cell injury. Okay? But if the stimulus is removed, maybe the blood flow is resumed, the cell will go back to its normal resting homeostasis part. Okay? So that's how it goes. So let's look at the reversible injury. Okay? If the cell injury is mild or transient, then the injury is reversible. And so these are the two features that you can see in reversible injury. Okay? The first is generalized swelling. Okay? The cell enlarges. Okay? It's different from hypertrophy. Okay? In hypertrophy, the cell enlarges because it produces more protein. But what happens in cellular swelling is usually because there's not enough oxygen, the cells cannot maintain the normal proton pumps, like your sodium chloride channels. So what happens is there's an electron imbalance, and so water will sweep or will seep into the cell, causing it to swell. It's not that the cell is growing, the cell is being infiltrated by water, and it's become enlarged due to accumulation of water. That's cellular swelling. And this is the earliest manifestation of cell injury. And the cytoplasm will appear more red in color. It becomes eosinophilic red. The other type of reversible injury that you can see is called fatty change. Okay? Fatty change, though, is limited to cells that are associated with lipids. Okay? The most common of which is easy to identify, is the liver. Okay? The liver processes a lot of your lipids. So if the cells of your liver get injured, for example, you drink a lot of alcohol, it will accumulate lipid droplets. So you would see lipid droplets within hepatocytes. That's a sign of reversible cell injury. Let's take a look at that. Okay. And then under the microscope, we have others. This is the electron microscope. We don't have the electron microscope. You will see all these alterations. Okay? I don't deal with that. So here's cellular swelling. You have an injury, and then water will leak inside the cell. Okay? And you could also have enlargement of various mitochondria and other organelles. So here's what it looks like in the microscope. This is a kidney tubule. Okay, what's lining at the filling of the kidney tubule? Simple tubular, okay? Microvilli. It's actually microvilli, although in our lab they're not very prominent. Okay? Because the microvilli in the kidney are very fragile. Okay? So here is the microvilli. This is a normal kidney. Take a look at the kidney here that has injury. You'll notice that they are really dark red, especially here. It's really dark red, and it's also swollen. Okay, it's cellular swelling. And then on the right is actually they're dead. Some of them are dead. They've lost their nuclei. They're dying. Okay? So we have normal, injured, and dying cells. Okay. So let's look at fatty change. So you have the accumulation of lipid droplets, or lipid vacuoles. Okay. They can start as small droplets, but they can combine to form larger droplets that can also distend. And it looks like an adipocytes. But here's what it looks like. Here's a normal liver, okay? Smooth, tan to brown. Okay? Here's the normal histology of the liver. Okay? These are the hepatocytes. There's a central vein there. We'll learn about the liver later. But I just want you to see what it looks like. These are the normal hepatocytes. Okay? And the white area are the capillaries. Here's the central vein. Now, here's another one of the portal triad, which we'll learn later. Okay, but you don't need to know now. And here's what it looks like when you have it grossly with a fatty liver. You'll notice the normal is brown, but then as you get more, it starts to take on a yellowish hinge to it, right? Because fat is like yellow. Then microscopically, they look like you have these adipocytes, right? You have that clear lipid droplets here. So these are the lipid droplets, okay, that are found within the hepatocytes. So that is fatty change. So the most common cause of fatty change is usually alcohol abuse, okay? Alcohol abuse, as well as obesity, okay? Fatty liver disease, also known as steatosis, but you don't need to know that. Just call it fatty liver disease. Here's another one. This one you still have some normal here on the sides, but then you see these lipid droplets again. Again, lipid does not take up the state of HE, so it looks like it's empty. But it's not empty, it's filled with lipids. Here's another one with severe cases. There's a lot of lipid droplets in these cells. So lipid droplets. Here's another one. I have a lot of pictures. The lipid droplets are here. That's fatty change. Here's a normal liver, but here's the one with the fatty change. All right. Next. That was the sign of your reversible injury. Okay? What happens if it becomes irreversible? If it becomes irreversible, eventually the cell will die. Okay? And there are two major ways cells can die. But it's not always perfect. Okay? You have necrosis and apoptosis. Okay? Necrosis and apoptosis. Those are the two ways cells will die. So, the two types of cell death, apoptosis and necrosis. So let's talk about some of the general features. Okay? For necrosis, it's an unregulated death. Okay? What happens in necrosis is the contents of the cells will leak out. Okay? The cell will leak. It starts to leak its contents. And then when the cell leaks its contents, this will elicit a strong immune response. So your immune cells will go there and clean up the debris, okay, or try to repair whatever damage is there. Apoptosis, the nickname of apoptosis is programmed cell death. Okay, it's programmed cell death, to a point. It can actually be physiological. Apoptosis can actually be physiological. And I'll show you examples later. What happens though is the cell breaks into small chunks, but these chunks are membrane bound. So it doesn't actually release its contents. It breaks into smaller bite-sized pieces, so to say. And these pieces are called apoptotic bodies, which are then taken up by the macrophage, by resident macrophage. And it does not elicit a strong inflammation. Okay? So the classic example of apoptosis, you see this a lot during embryogenesis. Okay? During embryogenesis, if you look at the embryo, you'll notice that the embryo, even in humans, we have a tail, right? The embryo actually has a tail. But those cells that form the tail will actually die. And that's why humans now, they don't have a tail. Another example is in early stages of embryogenesis, the fingers are actually webbed. Fingers are actually webbed, but the cells still will die. But if the cells don't die, but you get those people with the fusion of the fingers. Okay? Common disorder. Syndactyly. Okay? Another example though for adults, you have your immune system. Okay? Your immune system is designed to fight off many different foreign substances. But sometimes the immune cell will recognize itself as a foreign target. So what it does is it tells the cell to actually do apoptosis, because if that cell were to get into you, it's going to attack itself. So that's another apoptosis. Alright, so let's look at it. Necrosis is the death of tissues, okay? It's usually pathological and it's a consequence of severe irreversible injury. Okay? Severe irreversible injury. So what happens is the proteins become denatured and there's leakage of contents and there is a local inflammatory response. And then everything will be cleared up by the macrophages via digestion of the injured cell. Okay? Grossly, necrotic cells also are dark red and they may have a glassy appearance. Okay? But what's striking are the nuclear changes. Okay? So these are the various nuclear changes that you can see. You can have karyolysis, which means the normal blue color of the nucleus fades away. You can have kypnosis, meaning the nucleus is shrinking. Okay? You could have shrinking of the nucleus. Or you could have karyohexis, where the nucleus is now being broken up into several small fragments. Okay? Those are some of the nuclear changes. And eventually, the nucleus will actually disappear. Okay? So here's what it looks like in the diagram. Okay? Kypnosis, it's losing its blue color, karyohexis, and karyolysis. Okay? Let's look at the table. So this is the table from Robbins. Okay? So comparing necrosis and apoptosis. Okay? So in necrosis, what happens is you have the swelling. Okay? Again, there's injury because of whatever cause. Water is entering the cell, causing swelling. Then the nucleus, you can have those features. The plasma membrane becomes disrupted. Okay? And because it gets disrupted, the cellular contents may leak out of the cells, causing frequent inflammation. Okay? This is usually pathologic. Okay? As opposed to apoptosis, what happens in apoptosis, the cell will shrink, and then it's broken down into fragments. And so what is called apoptotic bodies, which I'll show you later. And there's usually no inflammation. So here's the example. Take a look on the left, you have necrosis. Notice that the contents are leaking out here, okay? And the cell is becoming larger. Whereas here in apoptosis, it's shrinking, and then it's fragmenting into these small bite-sized particles, which are called apoptotic bodies. Then these apoptotic bodies are just ingested by resident macrophages. There's no inflammation. Here on the other hand, we have heavy inflammation by your neutrophils. They have macrophages. Okay? Apoptosis, necrosis. Okay? Now, when there is a large amount of tissues that have died, we call that as necrotic or necrosis. And there are several patterns of necrosis actually. So we'll show you some of the patterns of necrosis. Okay? So when a large number of cells die in an organ, it's said to be necrotic. And there are several distinct patterns. These are the patterns of necrosis. We're going to look at them. We have coagulative necrosis, liquefactive, gangrenous, caseous, fat, and fibrillary necrosis. Let's look at the first one. The first one here is coagulative necrosis. Okay? So coagulative necrosis means it maintains its architecture. So it's like if you ever fried an egg, when you break an egg, it's liquidy, right? The egg yolk and the egg whites are liquidy. But when you heat it on a pan, it becomes solid, right? So you get your fried egg. That's what happens here. So here we have a picture of a kidney. And this portion of the kidney, you see this yellow area? That yellow area became injured due to a blockage of blood flow. So there was an infarct, okay? Decrease in blood flow. So that yellow area, the cells there died. Okay? But when it died, the type of necrosis is coagulative necrosis. So they maintain its architecture for a while. So when you look at the histology here, here's the histology of the kidney. See, we see a glomerus here. Here's a glomerus. Okay, these are the kidney tubules. But compare the lower left portion with the upper right-hand corner. Okay? You'll notice that the upper right-hand corner, see these kidney tubules? These kidney tubules have no nucleus because the cells here are dead, but they're still maintaining the shape of a kidney tubule. Okay? That's coagulative necrosis. Architecture is still there, but they're just dead. And then in between, you see a lot of inflammatory cells. Eventually, these inflammatory cells will digest and eat up the tissues there. Okay? So that's coagulative necrosis. They're maintaining its architecture. Okay? Here's another type of tissue. You don't know this one yet, but this is cardiac muscle. Okay? This is cardiac muscle. But you'll notice there's no nucleus in these cardiac muscle cells. And they're also quite pink. And you see here, these are inflammatory cells. So this cardiac muscle here is dead, but it's still maintaining the shape of a cardiac muscle because the cardiac muscles are elongated and they're branching. You can see the branching pattern here. So it's still maintaining the architecture, but these cells are dead. There's no nucleus, okay? And there's a lot of inflammation. So this is cardiac muscle that died. So the patient had a heart attack or myocardial infarction. Here's what it looks like grossly. Here's the area of infarct, this yellow area. Okay? There it is. This one here at the lower is scar tissue from a very old. This is what it looks like if it's still fresh, but eventually you'll have scar tissue. So this guy is very unlucky. He survived one myocardial infarction only to be killed by another myocardial infarction. Okay? Next one we have fat necrosis. So fat necrosis is when fat cells die. Okay? This is commonly associated with acute pancreatitis. Okay? Acute pancreatitis. This is the prototype of where you see fat necrosis. Okay? So the pancreas, the function of the pancreas, it's both an endocrine and an exocrine gland. So the exocrine portion of the pancreas is that it produces a lot of digestive enzymes to break down food. Okay? One of the most important enzymes that they produce are pancreatic lipase. Okay, pancreatic lipase. Okay? Lipase is an enzyme that will digest lipids. Okay? So what happens in acute pancreatitis? The two most common causes of pancreatitis is usually you have a blockage of the pancreatic duct via a gallstone, or the patient is a chronic alcoholic. Okay? Again, the reason not to drink. So what happens in acute pancreatitis is pancreatic lipase is supposed to be released into the small intestines, where it acts on the food and digests on the lipids. But because of obstruction or chronic alcohol use, the pancreatic lipase is released within the pancreas so that it will digest itself and the surrounding fat instead of being released into the digestive system. So when it digests itself, the fatty acids will solidify and produce these characteristic chalky white deposits, which is called fat saponification. For those of you who made soap is actually made from fat. Okay, so that's fat saponification. I'll show it to you. So what you see are dead necrotic fat cells. Okay? So here's what it looks like. You see these little chalky white deposits here? That is the area of fat necrosis where it underwent saponification. Okay? So the fat lipase was digested and solidified here. This is the pancreas. Okay? Usually you see this in patients who have very heavy binge drinking. They're severe chronic binge drinking, and then they wake up the next morning they're dead. That's the most common cause. And you see the pancreatitis. So you drink a lot, they go to sleep, dead the next morning. Very deadly fat necrosis. Here's what it looks like microscopically. This is what's left of the unilocular adipose tissue. It's kind of destroyed. You can see that they don't look like its cells. They have no nucleus. It's more pink, and they're distorted, and they're broken down. Fat necrosis. Here's another one. Again, it still maintains its shape, but this is fat, but there's no nucleus, and there's a lot of pink. Okay? Fat necrosis. This one has a lot of inflammatory cells here. The inflammatory cells are here. Those little dots, those are, most of them are neutrophils. Okay? And those are fat cells, surrounding the fat cells. Right? Next we have liquefactive necrosis. So in this one, it's different from coagulative, because in liquefactive necrosis, the tissues will turn into mush. It liquefies. It turns into like a soup, because it's broken down by enzymes. Okay? This is very common in the central nervous system. So when cells die in the central nervous system, they usually have a characteristic liquefactive necrosis. And it's not known why the central nervous system is prone to liquefactive necrosis, but it just is. So here we have This is a brain that underwent an infarct. So we have this cavity, this is where the infarct was, and then the tissues kind of just melted and became liquidy. So that's liquefactive necrosis. Okay? Another example of liquefactive necrosis is actually pus. Pus. Okay. I'm sure you're familiar with pus, or if you ever tried popping a pimple, you get that white stuff, right? That white stuff is predominantly white blood cells and dead cells and necrotic tissues. It's a liquid, right? When you pop it, it's like liquidy, somewhat liquidy. So that is pus. Another example of liquefactive necrosis. So here we have a neck abscess. This is what it looks like in the microscope. Okay? So here, this is a liver. So what the liver did is it surrounded the abscess. So we have this little surrounded area. And then in the middle, it's just a lot of inflammation and dead cells. So a lot of neutrophils, dead cells. Sometimes there's bacteria if the cause of the dead cell were bacteria. So that's what it is. Here's what it looks like in high power. It's just a lot of neutrophils. There's no architecture because it's not coagulative, so you can't see any normal structures. It's all liquefactive. So just neutrophils, dead cells, possibly bacteria. Okay, that's low power brain, that's a high power brain. Next one, this comes out on the exam. This came out on my board exam. Caseous necrosis. Caseous means cheese-like. Cheese-like. Because when you look at it grossly, doesn't it kind of look like crumbled cheese? Sort of? Caseous necrosis, cheese-like. Originally, caseous necrosis was associated with tuberculosis, and we know tuberculosis is very rampant here in the Philippines. Okay? Caseous necrosis. What actually happens in caseous necrosis is the immune system cannot kill the bacteria of the cause. In this case, let's say, for example, tuberculosis. But it's not the only example of caseous necrosis, but we'll use tuberculosis. Tuberculosis is a very stubborn bacteria, very stubborn. The dust cells of your lungs or your macrophages of your lungs, they can ingest the mycobacterium. But once inside in the mycobacterium, it can't kill it. So it ingests it, but it can't kill it. But since they can't kill it, what they tend to do is they try to quarantine the entire location. By quarantining it, they have caseous necrosis. So it's the body's attempt to quarantine a very stubborn bacteria or cause. Okay? So let's take a look at what it looks like. So here's another one. This is actually a lung of a patient with tuberculosis. Okay? That cheesy white area. That's what it looks like grossly. Here's another one. And here's real cheese to compare. So we have blue cheese and feta cheese. Okay? So they kind of look like caseous necrosis, hence the term caseous necrosis. Now, microscopically, caseous necrosis is associated with a very interesting type of inflammation which we call granulomatous inflammation. Okay? Granulomatous inflammation. Okay? Now, granulomatous inflammation can actually be caseous or non-caseous. Take note of that. Okay? So, granulomatous inflammation can be caseous or non-caseous. Okay? So, what you actually see is something called a granuloma. Okay? You see a structure called a granuloma. So, a granuloma is going to be, I'll show it to you. So, the structure you see is a granuloma. This is a granuloma. This is a granuloma with caseous necrosis, but not all granulomas can have caseous necrosis. So, but if you see caseous necrosis, the caseous necrosis is in the very center. Okay? It's this very dark pink area. That dark pink area represents the dead tissues. They're dead tissues. Everything there is dead in the middle. That's caseous. That's the caseous part. And then surrounding it, you see a lot of these macrophages. Okay? There's a lot of macrophages that surround it. That's these pink lines. Because they're trying to kill off the bacteria, but they can't. So they're forming like a macrophage wall. They're going to wall it off. They're like holding hands and saying, do not exit quarantine area. And sometimes these macrophages will combine to form a very large cell, which is called the Langerhans giant cell. Langerhans giant cell. That came out on my exam actually. The Langerhans giant cell was also initially associated with tuberculosis. Okay? But nowadays we know that caseous necrosis and Langerhans giant cells can also be found in other diseases, like fungal diseases. Okay? So the Langerhans giant cell is a very large cell. You can really see it. Very large cell, and there are several nuclei, and the nuclei are arranged in a little U shape. It's shaped like a U or a horseshoe shape. Okay? It's just a collection of macrophages that combine its power. So they're like the Power Rangers where they form their megazords. When their power combines, they form this giant megazord. Okay? Perhaps I'm too old for you guys to know that reference. So yeah, they're combined macrophages to form a giant powerful cell. Okay? And then surrounding that, you see more epithelioid cells that are trying to block off. So let's look at it histologically. So here's what it looks like histologically. This pink area that's like really homogeneous and pink, that's the caseous area. That's the caseous necrosis. Then see these large cells that are kind of like U-shaped? They're very large. There's one up here, and there's a few here, and then here too. Those are the Langerhans giant cells. Okay, Langerhans giant cells. And then all the other cells here that are surrounding it, usually they're epithelioid macrophages, and then the last wall are your lymphocytes. Okay? They're trying to quarantine the location. Okay? That's their attempt. Right? Here's what it looks like in another microscope. So here, the caseous necrosis part, the pink. These are the epithelioid macrophages. Okay, this one doesn't look like they have any giant cells though. Here's another one. Here's the caseous part. Here's the giant cell. And the rest of the background cells are just macrophages. Here's another high power view. This part here is the caseous part, okay, the dead cells. Most of these cells here are just macrophages. Okay, these are just macrophages. The giant cell is here at the lower corner. There's the Langerhans giant cell. Here's another one. This one is non-caseating though. This one's non-caseating because there's no pink area. So sometimes you could have granulomas that are non-caseating, meaning it doesn't have that solid pink area. Okay? Now let's look at some of these giant cells. So the first one I showed you on the left, that's your Langerhans giant cell. Okay? Do not get it confused with Langerhans. Langerhans is something you see in the skin. It's a special cell. So Langerhans and Langerhans are two different people and they're two different cells. Just their names sound the same. So take note of that on the exam because many students mix it up. So it's Langerhans giant cell. Okay. So the Langerhans giant cell, it's characterized by multinucleation and it's usually shaped in a horseshoe shape. Sometimes though, you can have them on both sides, so kind of like two U's. But most of the time, they are in this pattern. Okay? This one is going to be associated with your granulomatosis inflammation. The other types of giant cells we have is we can have foreign body giant cells. So usually you see this a lot when in the skin, when there's sometimes like you get a splinter in your skin or a foreign subject in your skin. So the macrophages will combine and they form a giant cell, but their nuclear arrangement is not in a U shape. It's just scattered all over. So it doesn't have that horseshoe shape or the U shape. That's the foreign giant cell. Then another one we have is called the totan giant cell. Okay? The totan giant cell, it has this ring of nucleus, and then surrounding that ring are lipid droplets. So this is associated with injury where there's a lot of fat injury, okay? And certain tumors that are related to fat. You don't need to know that now. Okay? Just know the regular arrangement of the totan giant cells. See a little circle and then lipid droplets around it. Totan giant cells. And then sometimes tumor cells themselves can actually be very large and multinucleated. Okay? But take note, when you look at tumor cells, their nucleus looks really weird. Okay? They can be really irregular, different shape, and they can be really dark appearing. Okay? So, as opposed to the non-tumor cells, they usually have a very uniform nucleus. They should have uniform nucleus. So we're going to look at them. Here is the Langerhans giant cell, the C shape. Here is the totem giant cell on the right, and then there's a foreign body on the left. Okay? Notice the arrangement of the nuclei. It's just scattered in the foreign body. And then here we have that circular arrangement with the lipid droplets surrounding it. It's a totem giant cell. And of course, take a look at this one. This is a very bad carcinoma. The nucleus is completely shaped weird, very weird, irregular, and very large and very dark. That's cancer. Alright, we're almost there. Here's a non-cacheating granuloma. There's no caseous necrosis in the center. So some granulomas, they can be cacheated or non-cacheated. Next one, we're almost there. We have something called fibrinoid necrosis. This is something you don't always see because this is associated with vasculitis, okay, and autoimmune diseases. So what we actually have here, this is a wall of a blood vessel. Okay? The lumen is here. Here's the lumen. Here's the epithelium. But the layer is very irregular. And you have, what's very characteristic is you have this pink line. See this pink ring going around it? You may think it's caseous, but it's not caseous. Caseous is not supposed to form a ring. It's supposed to be in the center of a granuloma. But they kind of look similar because they're pink, but they're different. So this fibrinoid necrosis occurs in a blood vessel, and it's usually due to autoimmune or vasculitis syndrome. Okay? So what happens is you get this fibrinoid material that will actually deposit in the wall of the blood vessel. Okay? So that's what's happening in fibrinoid necrosis. We don't usually see it. We don't usually biopsy for that. So that was the different types of necrosis. Now let's look at apoptosis. So apoptosis is programmed cell death. Okay? It's basically a suicide program for the cells. Okay? It can be physiologic, and it can also be pathologic. And this is actually one of the defense mechanisms that the body has against cancer. Okay? So if the body detects that a cell is cancerous, what it's supposed to do is it's supposed to initiate that cell to undergo apoptosis so that it doesn't spread. But of course, cancer is clever and has found ways to avoid apoptosis. Okay? So programmed cell death. Okay? Causes, okay, very common for physiologic during embryogenesis. Okay? You can also have it in hormones. So for example, let's say you have the hyperplasia in pregnancy. Now she's no longer pregnant and the baby is no longer breastfeeding. The glands will atrophy and then they will undergo apoptosis and the breast will go back to its normal resting state. So that's physiologic. Okay? Other ones. Pathologic, DNA damage, anti-cancer drugs, misfolded infections. Okay? Don't need to know so much. Okay? So what are the changes? The cell here will shrink. Okay? Unlike in necrosis where it's swelling, what happens here is it shrinks, the chromatin will condense, and we form blebs, which will eventually become apoptotic bodies, which are little kind of bite-sized fragments for the macrophage to digest. Okay? Here's what it looks like I showed you earlier. Okay, almost done. This is the last topic. Next, we have calcifications. Okay? So sometimes tissues will become calcified. Okay? So the abnormal deposition of calcium salts and other substances is known as calcification. Now we have two forms of calcification. Dystrophic calcification and metastatic calcification. The most common is actually going to be your dystrophic calcification. Okay, that's your dystrophic calcification, most common. So let's look at these last two forms. Okay. So dystrophic calcification occurs in areas of necrosis. Okay? So sometimes when there's injury and necrosis, it's not uncommon to see calcification. Okay? Because there's calcium in cells sometimes, so the calcium will solidify if they're dead. The best example for this, though, is seen in two situations. The heart valve, particularly the aorta, and in your blood vessels, where it causes atherosclerosis. Okay? And then the serum calcium levels of these patients, they're actually normal. Okay, so take note. It occurs in sites of injury, and the serum calcium level is normal. Okay? Because metastatic is opposite. Okay? So here is a normal aortic valve. Okay? You'll be looking at this later in the next block. Okay? So this is a normal aortic valve. We're looking from the aortic portion. So we're up on top of the aortic, and then if we were to go past that valve, we'll be in the ventricle. This is an aortic valve that has dystrophic calcification. So you see these little chalky white things here? That's the calcified area. Okay? This is commonly seen in elderly. Okay? Usually they have an abnormal development of their aortic valve. So the problem with this is because you have the calcification, sometimes the valve will not operate functionally properly. So sometimes it doesn't close all the way properly. It could cause a lot of regurgitation problems. Okay? So that's dystrophic calcification of the aortic valve. So grossly, you see deposits that are fine white. Okay? And when you try to feel it, it has like a sandy-like thing. It's like sand. The histological appearance is you see these crystals, these basophilic amorphic granular crystals. Okay? Now sometimes you can have single cells that become calcified, and then these single cells will develop layers and layers of calcification around it. And that's called a psammoma body. Okay, psammoma body. Psammoma bodies are seen in they're seen in a lot of conditions. But the most common condition that you see psammoma bodies, and I'll show you later, are number one, you see it in thyroid cancer, specifically papillary thyroid cancer. So papillary thyroid cancer. Next, you see it in